Good morning and afternoon to those coming in from other states. We welcome you today to a very important conversation, protecting patient care, understanding the effects of Medi-cal budget cuts. I'm Liz Helms, the President and CEO of the California Chronic Care Coalition, and we will be introducing an amazing panel of presenters that have a great deal of experience in working with Medi-cal. I know that we've all been super interested in what's happening with Medi-cal this year, with the cuts, with the changes, with the utilization management that they're adding into it. So I'm going to go ahead and get started. And so our speakers today, Connor Sweeney is the Regional Manager in State Policy and Advocacy for Susan G. Komen. Welcome, Connor. Casey McPherson is the Director of Clinician Advocacy for the Alliance for Patient Access, and Lynn Kinst for the Disorders Council of California, among many other hats that she also wears. And she is also our interim chair of the California Chronic Care Coalition and the Rare Disease Coalition that she put together. So all of our people speaking today are very involved in so many, wear so many hats, and we're so happy that they're taking time to join us today to talk about this very important subject. So I want to give you just a quick overview, and if you have questions, please put them in the chat. This year, we have had so many issues put on patients. Sometimes we feel like a patient-centric healthcare system is leaving us. We as patients don't want that to happen, and so our voice is incredibly important. So today we're going to explore the potential implications of the budget cuts and utilization management tactics on Medi-cal beneficiaries, really focusing in on the patients. As patient advocates and allies, it's crucial for us to understand how these legislative changes would affect our communities. All of our communities will be affected. What we hope you will learn today during this session, we'll examine key provisions of the May revised trailer bill, including the implications of weight loss drugs being omitted from Medi-cal, continuity of care provisions, understanding the potential impact for the new requirements for prior authorization, and how they may affect access to necessary medications for beneficiaries, especially for the cancer and HIV community. So here's a little bit about the California Budget Act. SB 101 and AB 102 were passed by the legislature and signed into law by Governor Gavin Newsom. The state budget package also includes trailer bills. Trailer bills generally make changes to state law related to the Budget Act and, like budget bills, move through the legislature's budget committees. AB 116, the Health Omnibus trailer bill, was signed by the governor on June 27th, so it hasn't been that long. Although time is going so quickly, it's hard to believe we're going to be into September here in a few days. You can find an overview, a summary on the California Chronic Care Coalition page. This has a link to it. We will be happy to share with you this PowerPoint presentation after. And then also you can find the bill, AB 116. Also, here's a link to that. So feel free to go to those, read them if you haven't already. There's a lot of really great information. We tried to simplify it. Our policy counsel, Alex Kahn, did a great job pulling that all together and getting it up on the website. So let's talk about utilization management in Medi-cal. So I'm so happy to bring Connor Sweeney. Connor's also on our board, and this is very close to his heart and to the people that he represents. So welcome, Connor.
Thank you, Liz, for the introduction. Good morning, folks. We really appreciate you guys attending this webinar. We've got a lot of really important information for all of the chronic disease populations that you represent. And as mentioned by Liz, I'm going to kick off our discussion here talking about our concerns with utilization management being introduced to the Medi-cal program. In particular, step therapy. Liz mentioned this is very near and dear to my heart and to Susan G. Komen. We've been working on step therapy reforms for many years now. So very pleased to be here to talk about this. So included in the enacted budget are plans to implement utilization management, step therapy protocols, and prior authorization for prescription drugs in Medi-cal. So if you're not familiar with those terms, prior authorization, step therapy are forms of utilization management, which are practices that are typically used by private insurers to control their costs. And unfortunately, we often find that these cost controls come at the expense of patients' health. So prior authorization, it's pretty straightforward. Before a patient can receive a prescribed drug, the health plan has to approve it. If the health plan doesn't approve it, this can really turn into a back and forth struggle between the provider and the patient and the health plan to get the necessary care for a patient. So if you've been following SB 363, which is the coalition is a sponsor of, you know that prior authorization denials are very common and that many are later overturned by an independent commission due to medical necessity. Step therapy is a much bigger concern, I would say, for Komen. It is often referred to among the patient community as fail first protocols. Under step therapy protocols, a patient must first try a lower cost or insurer preferred drug before the plan will cover the treatment that was initially prescribed. Only once the first drug fails will coverage for the prescribed drug be considered. Why is the state introducing these potentially harmful practices into Medi-cal? Well, like several of the items we're discussing today, the significant budget deficit plays a role. The administration projects that step therapy and prior authorization in Medi-cal will generate over $350 million in savings over the next few fiscal years. And while the exact details of this proposal are still pending, they're still withstanding, but today I want to share how utilization management and step therapy in particular can affect patients with chronic diseases. I will be approaching this from the lens of cancer treatment, and I know that there are many other chronic diseases being represented on this call, but I hope this illustrates the broader implications and it helps you assess how it might impact your own constituencies. So here's how step therapy in cancer treatment might look. A patient is diagnosed with, let's say, metastatic breast cancer. Their oncologist prescribes a newer FDA-approved targeted therapy. And instead, the payer requires that patient to first try an older, less targeted, more toxic drug and to fail on that drug first. And keep in mind that for this population, failing treatment pretty much means failing to stop the cancer from further spreading throughout the body, which leads to even more serious complications and an even lower 5-year survival rate for that patient, unfortunately. That is why my organization has long advocated to prohibit private insurers from applying step therapy to patients with advanced cancer, and to now see this practice potentially being implemented into Medi-cal is very discouraging, particularly because Medi-cal covers such a large percentage of Californians. I believe it was about 38% as of January, not to mention that Californians enrolled in the breast and cervical cancer treatment program receive their treatment through Medi-cal. This is all very troubling to us for several reasons. First, because step therapy protocols have a lack of personalization. They often rely on generalized data and do not account for individual circumstances. They generally don't account for comorbidities. And we know that we're in an era of very personalized, very precise cancer care, especially when it comes to metastatic disease. Treatment is highly individualized and guided by the patient and the provider, not by the payer. So we're in an era where cancer treatment can be driven in a certain direction by biomarker testing, genetic testing. This can really improve patient outcomes, but not if step therapy and prior authorization get in the way of that. Metastatic cancer can't be cured. Treatment is ongoing. It's for life. It's about stopping progression and preserving the patient's quality of life. So any delay whatsoever can be really devastating to those folks. On top of that, symptom management really comes into play with step therapy. Many metastatic cancer patients depend on supportive drugs to manage the side effects, the nausea, the impact on their bones, all these nasty side effects of chemotherapy and these other harsh treatments. Those drugs are often subjected to step therapy as well, which can really hurt a patient's quality of life. So I mentioned that this is typically billed as a cost-saving tool, but a lot of studies and a lot of research show that it can be the opposite. A study published in the American Journal of Managed Care actually found that step therapy not only creates barriers to access, but it can ultimately drive higher medical utilization costs. And if anybody out there is from a group representing Crohn's disease patients, I saw a study recently actually that showed that step therapy, if used in the course of Crohn's disease treatment, actually increased the cost for the payers by up to 37%. So, a lot of really big challenges with these being introduced in Medi-cal. I do want to say, it's worth noting that California law does provide for step therapy exceptions that can be requested by the healthcare provider when they believe the protocol is clinically inappropriate, like if there's a risk of worsening comorbidities or a significant impact on daily function, prior evidence that a drug has been ineffective. But with that said, those safeguards place an additional burden on providers who have to take time out of their day to compile all that documentation and file those exemption requests. We know very well that all of those additional burdens on providers takes time away from patient care. So obviously, we're very mindful of the difficult financial situation that the state was facing this year, made worse, of course, by the passage of HR 1 in Congress. So what's next? Komen, and I'm sure the greater coalition will closely monitor how step therapy and prior auth are ultimately implemented in Medi-cal. We will advocate as needed to ensure that the patient voice remains strong, that patient protections remain available. I encourage everybody on this call to watch that process carefully and consider how these changes and the ones that my colleagues are about to share can affect the patients and constituencies that you represent. But that's all I have for now, Liz. Of course, we'll be around to answer questions at the end, but for now, I want to pass it back to you.
Yeah, thank you, Connor. Very heartfelt discussion. And, what has also gone alongside of the prior auth and increased utilization management is in the HIV community. They they put the two of you together, pretty much HIV and cancer. I remember in the late 1980s and early 1990s, there was no treatment. You had HIV and then you went into AIDS, and I lost 6 friends within 2 years of each other to AIDS. And then here came the research and here came the medicines. And now fast forward to today, we're looking at HIV as a chronic condition. People are not dying from it. And when you add in another barrier or another layer, like for cancer, it's time. People don't have time and they need to get started, and the doctor needs to be the one to make that call, make that decision, which will move us right into Casey. who is going to be talking about that, and the physicians. So, Casey, welcome.
Thanks so much, Liz. Happy to be here, and I'll echo Connor and saying thanks everyone for taking the time to join. We know it's a busy time of year and folks have a lot going on, but excited to be able to participate in this conversation. I'm going to talk briefly about some of the things that Connor touched on in the utilization management space, but also want to bring up another topic of cuts that we are going to see here shortly in the obesity space. But I will start by just introducing myself and the Alliance for Patient Access. So, as Liz mentioned, Casey McPherson, I'm the Director of Clinician Advocacy with AFPA. We're a national nonprofit made up of healthcare providers. And so our main constituency is really that clinician perspective. And our goal is to utilize that clinician's voice, that provider voice, to inform health policy decisions that ultimately lead to a system of patient-centered care. We work with over kind of 1,000 clinicians across the country in a variety of disease states, about 25 or so different disease states. And within California, we actually convene a California state chapter comprised of about 150 or so docs from across the state that are, active in conversations regarding access to care in California. And so, as I mentioned, I want to talk about kind of two main topics today. The first being the obesity side of this conversation. And so, as Liz mentioned from the outset, one of the things that was included in this budget was the elimination of coverage for GLP-1s for weight loss starting January 1, 2026. I will flag that people with type 2 diabetes will retain coverage. You will get to keep it, but Medi-cal beneficiaries seeking GLP-1s for obesity or weight loss or receiving GLP-1s for obesity or weight loss will lose the coverage of that benefit. To Connor's point, this is ultimately driven, it's a cost conversation. It's ultimately driven by, making sure that the state is able to keep costs down. And I think they're estimated to save anywhere from 85 million next year to up to 790 million by 2029 by making this change. And so a fairly significant dollar sign attached to it. But it is something that we're actively monitoring. One of the things that we've heard in regards to the dollar sign that is attached to this is that, without getting too into the weeds, there's concern that this might not actually be truly representative of state cost when factoring in things like manufacturer rebates or federal matching funds. The big 790 number might not be the most accurate. But again, without getting into the weeds, it's hard to say exactly. The other thing that we hear from our healthcare providers, at least, is that this really fails to understand and take into account the cost savings from a patient who is stable on medication. I mentioned that we work across a variety of disease states, and obesity is a topic that comes up across the board, whatever kind of therapeutic area our providers are treating patients in. They recognize that obesity plays a role in it. And, one example that I hear or that we heard last year was a rheumatologist based in the LA area was treating a patient with osteoarthritis. This patient had seen pretty severe degradation of their knee joint. And one of the things that was contributing to that was their obesity. And the clinician mentioned that, there's options until we're able to kind of get this under control. It is going to complicate our ability to treat the osteoarthritis. And so the rheumatologist was able to get the patient on a GLP-1 and see significant weight loss from the therapy. And with that, they were able to avoid a knee replacement. They knew that a knee replacement is where they were headed. But when the patient was able to kind of, recalibrate a little bit and lose weight with the help of the therapy, they were able to change their lifestyle entirely. They were then ultimately able to manage and regulate their osteoarthritis and avoid a complicated, expensive procedure with the knee replacement. And so I think that's one example. We hear from our clinicians across the board about how important this is. We have obesity clinicians who focus on obesity, who are specialists, who are active in this conversation and mention that this is the best product they've ever had a chance to use. They haven't had a chance to really tackle this disease at its core until recently. And the concept of potentially losing the ability to use this tool in their toolbox is a harrowing one for them. And so I know we're going to talk a little bit more about it later, but I mentioned that as something that, it impacts, I think, a wide range of specialties. It's not just a one disease state issue. It's something that impacts a lot of our, at least AFPA's constituency as far as clinicians across the board. So that's kind of the first topic. The second one gets into what Connor was just talking about with the utilization management. And again, I want to kind of bring through the clinician's perspective here. whenever we talk to our providers, the biggest issues that they flag are always prior authorization and step therapy. They recognize that there might be a role in this. Step therapy is often taught in medical school, maybe not to the extent that we're currently seeing now, but understanding that, trying options to see what is the most effective for that patient is important. The concern that our clinicians have is that far too often this is becoming something where they are not the ones making these decisions. These are insurer mandated steps, or in this case, Medicaid mandated steps. And it's of concern for them. I think this one, again, as Connor mentioned, you're looking at several $100 million potential savings here. But what we often try to emphasize is that a patient who is stable on medication, that you can't really put a dollar amount on that. It's difficult to project that. It's difficult to forecast that. But recognizing the just severe and significant importance of a patient remaining adherent, remaining stable, and the continuity of care impacts that Liz talked about. So one of the things that AFPA worked on a few years ago that I'm sure many people on this call were active in was the passage of step therapy legislation. Obviously, it's a different kind of patient population, but that was a huge advance. That was extremely exciting for patients in California, for providers in California, to recognize that this issue that was, burdening them was finally going to be addressed by the legislature. And so when we see things like this come in that don't necessarily undo what was done, but it's a balloon animal a little bit. You push in one area and it pops up in the other. And so there's a concern that while we've made some advances, it's a little bit of a step backwards. The other thing that I think is interesting when it comes to utilization management is that this is, as I mentioned, we hear about it from all of our clinicians across the country, regardless of their therapeutic area, regardless of their disease state that they're focused on, has this pretty significant barrier to their ability to practice care. And so we actually published a survey in 2024 that was published in the American Journal of Managed Care, looking at utilization management and the role that it played in physician burnout. And what we found was that 99% of physicians said that prior authorization was a barrier. 98% of physicians said that step therapy was a barrier. And 55% of them said they were working on utilization management kind of paperwork, or that administrative burden that we hear so often about outside of their work hours. This is uncompensated time that they're having to deal with kind of bureaucratic processes to allow their patients to receive what they see as the optimal care. That study also found that just about 50% of physicians were currently experiencing burnout. And of those 50% that were experiencing burnout, 93% of them said that utilization management was a significant reason for that burnout. And so, elevating this beyond kind of the day-to-day, this creates workforce shortage issues. I think we are all familiar with the fact that there's a clinician shortage, whether it be in primary care or specialists or mental health or whatever, what have you, there are clinician shortages. And this is a contributing factor. And I'll just kind of close with the concept that, the way that we look at it is, like I mentioned at the top, there are certain situations where step therapy is appropriate. There are certain situations where prior authorization might be, appropriate. That's not our concern here. Our concern is when this is used to manipulate what patients are receiving, manipulate that shared decision-making process that patients and providers come to when charting out their course of care. And so, ultimately what this does is it drives a wedge in that clinician-patient relationship, which I think is what we all strive for. And I think that is what we're concerned could be coming down the pike in California. So with that, I know there's Q&A later. I'm happy to answer any questions, but I will go ahead and hand it back over to you, Liz. Thank you.
Casey, thank you so much. I just, before we go any further, for some reason, where I am right now, we're having heavy lightning and thunder. So I have no idea if we'll be losing power shortly because it's coming like every few seconds. It wasn't in the forecast for today for here. If I do drop off, I'll come right back on, and Mary is the host, so this shouldn't go away. It just might go away for me for a minute. Hopefully that won't happen, but I just want to give you a heads up. Some things that we have that are beyond our control. Casey, thank you so much. We're running, we are the sponsor or co-sponsor actually with you guys of AB 535, Richardson, the obesity bill, and that is still moving forward. We have to get some updates because we're on the home stretch, and there's things that we're being asked to take a look at, but it makes no sense to me. I mean, just recently we did a interview with CBS San Francisco, and they went shopping with a patient who has been on GLP-1s, and they wanted to know what was going to, they want to talk to her when it first came out that this was going to be cut, that it was a potential of being cut. It's no longer a potential of being cut. It's being cut. And it was amazing because she's on Medi-cal. She's lost a lot of weight. She does not have type 2 diabetes. So now the state is saying, well, sorry, you know, even if you've been stabilized, and I think there might be some provisions in there, you're going to have to get type 2 diabetes to get the coverage that you need to get the medicines that you need, which doesn't make any sense to me at all. And we know that obesity affects millions and millions of people, and affects over 200 different chronic diseases, including heart and cancer and, not just diabetes, but a whole host of different diseases. And so this is just not acceptable. So we've got to keep working on it. And we really appreciate the partnership with the Alliance for Patient Access to move this forward. And we'll have questions and be doing a roundtable here pretty soon. So thank you so much, Casey. That was great information, and we'll move forward for the moment. Now, Lynn. Lynn is one busy lady. I mean, but if you ask Lynn to do something, she says yes. I've never known her to say no unless she is double booked already at that time. And so we're delighted to have her. Lots of energy, really cares about these issues. And I'm just going to turn it on over to you because I know you have a lot to say. So thank you and welcome.
Thanks so much, Liz. So we want to chat, excuse me, a little bit about, specifically how these cuts are going to impact rare and chronic disease patients throughout California. And of course, we have kind of some waves of what's impacting things. We're focusing in a great degree today on what has taken place with just the budget cuts to Medi-cal through this last budget cycle. But as I think most of you on the phone probably know, we're also looking forward and have concerns about what additional cuts will come as a result of HR 1. So some of the risks for chronic and rare disease patients really revolve around this pharmacy benefits. My colleagues Connor and Casey have already spoken to this, but the elimination of the GLP-1s, more utilization management like step therapy and prior authorization requirements, and then there's some additional layers as it relates to cancer and HIV drugs. All of these things can result in delays. I think that there is a study that has stated that the additional, prior authorization requirements can potentially delay a patient in receiving their medication up to 30 to 40 days, which, for folks in the bleeding disorders community, for example, that can result in a severe bleed, which could lead to death or severe joint damage, lasting damage that ultimately really is going to cost the medical system more. In addition, the budget cuts are reducing coverage for some of our immigrant populations. And then looking forward to the impacts down the road from HR 1. HR 1 will implement work requirements for many patients on Medi-cal, and it will also require more frequent renewals, right? So with that in particular, we're looking at dropping or increasing, I should say, the frequency to every 6 months that folks will have to, update and provide additional information to the state. And it's kind of like, imagine if you had to renew your driver's license every 6 months. I think there'd be two impacts of that. One, we would see a lot more folks driving with expired licenses because of the inconvenience of having to deal with all that extra paperwork. We would also probably see an additional backup at the agency at DMB, right? Because the staff would not be able to handle the volume. And that's one of our big concerns with these changes to Medi-cal are the state employees that are already in that department going to be able to handle the increased workload, or is that going to lead to more delays in processing paperwork and cause potentially patients to fall off Medi-cal who really still should be on Medi-cal and haven't actually lost their coverage. And then lastly, we are also concerned about potential increased premium costs in covered California. And we already know, because the insurers are already, issuing rate adjustments, rate filings for the coming year, that we're expecting increases across the board because insurers see everything that is coming, and they're expecting that a lot of people will drop coverage or lose coverage because they won't be able to afford it. And that's going to increase the cost for those that are trying to remain on their coverage, which, again, if you are living with a rare or chronic disease, you can't go without insurance, right? That's going to leave a pool of people left in the in the insurance marketplace that are going to be more expensive. And it's going to cause increases to costs across the board. Liz, can you send it to the next slide, please? So we wanted to give everyone some practical tools of, if you are concerned about losing coverage as a result of some of these changes, what are some steps that you can take now to attempt to protect yourself? So first of all, it's really important that everyone knows what kind of insurance they have. If you've been listening to the news, there's been all this talk about Medicaid. People don't necessarily know whether or not they have Medicaid, right? So in California, we call our Medicaid program Medi-cal. But most patients who are on Medi-cal are on a Medi-cal managed care plan, which means they may have an insurance card that says, Kaiser or Blue Cross or United or Health Net, and they may not even really know or pay attention or realize that they're on Medi-cal. So it's really important that you understand that you take the time to kind of look and know what your insurance is and what the source of it is. Is it coming from Medi-cal? Did you get it through Covered California? Is it your employer that's helping you access that plan? If you are on Medi-cal, make sure your contact information is up to date with the state, and make sure that you regularly log in to your account. You can access your account via the Medi-cal website, where you can log in and check on the status of your account. There is also an app that you can use. All Medi-cal patients should make a practice of being familiar with those resources and know how to utilize them. Make sure that your address, your phone number, your email address is up to date. And the reason that is so important is because they will be sending out notices letting you know if things are changing, if you need to elect a new Medi-cal managed care plan, if you need to respond with additional financial documents or other information. And so you must make sure that you are opening emails, that you are reading them, that you are checking your mail, and that you respond within the deadline, which typically is going to be 10 to 30 days that you're going to have to respond to a notice from Medi-cal or from your Medi-cal managed care plan. And then lastly, I would say, begin keeping records of your monthly work hours or other qualifying activities. So under HR1, the work requirements are not going to go into effect immediately. Most likely in California, they will not take effect until potentially sometime in 2028. I would not be surprised if California requests an extension. But in any case, you're going to want to begin to keep track of that. And besides work requirements, you can also meet that requirement through caregiving, school, community service. There'll be a number of ways to do that, but just keep open to that information, keep your ears to the ground, and then begin to track those qualifying activities and just have that documentation so that when it comes time, you'll be able to provide that. Next slide. So for Covered California, which again is the ACA plan here in California, on Covered California, what can you do? Well, first of all, make sure you're staying current on your premiums now, so that you don't have any kind of lapse of coverage. Again, like we talked about, read all the notices from Covered California and your insurance plan. Submit any required responses timely. If you are re-enrolling for 2026, don't wait till the last minute. There may be additional paperwork. You're likely going to have changes in your premiums. So you don't want to wait till the last minute to take a look at that. As I just said, anticipate higher premiums. You can go ahead and update your financial information and be sure that you filed your taxes and reconciled your credits from prior years now. Again, that's something you can take care of in the immediate. And then make an active choice for 2026, even if you're keeping the same plan. And then across the nation, protect yourself against junk insurance. It's kind of a great rule of thumb when looking at insurance across the board. The lower the premiums, the less either the less they're covering or the more cost you are going to have to pay out of pocket in order to get access to that coverage. So it's always a little bit of a trade-off, and you kind of have to look and see in your particular family situation, given your health concerns and the cost of your health care, how much premium can you afford, and then how are you going to balance that out on the other side in terms of what your out-of-pocket ongoing costs are going to be. Next slide, Liz. Okay, so related specifically to the Covered California issue, I did want to comment on this briefly because this is something that everyone can take action on right now. So, without going into too much complicated detail, as part of the work that was done at the national level on the ACA, there are tax credits that individuals who are using the health exchanges across the country can utilize. And there was an enhanced premium tax credit, which was passed by Congress and then extended, which really made that healthcare more affordable for folks across the country who were trying to access healthcare through the exchanges. Those tax credits expire at the end of this year. So unless Congress takes action to extend those tax credits, premiums will go up dramatically, and they likely will go up for folks across healthcare, not just those that are on the exchanges. So the graphic that I have here shows some information, and it talks about what their anticipated increase in California specifically would be. For a 60-year-old couple earning a little over $82,000 a year, their annual premiums would increase by 349%. Okay? A family of four earning just under $130,000 a year, their annual premiums would increase by 101%. And so you can see how much this is going to impact things. So there is a website listed there, or you can scan the QR code, and that will take you to a campaign that is being coordinated by the National Bleeding Disorders Foundation. And it will help you. It will actually give you an email that you can send to your Congress member. You can edit the email in the app. And, if I know we have lots of other disease states, not just bleeding disorders represented on this call. So you can adjust the content of that email a little bit to tell about your personal story, and then that will go off to your member of Congress and urge them to extend these tax credits. So hopefully those are things that will help, all of you prepare as you are looking forward to what's coming in the future, or help you as you're working with patient communities that need help preparing. So I think I'll pause there. And Liz, I think we're going to move into a time of Q&A in just a moment, right?
Yes, and Lynn, thank you so much. I also wanted to let everybody know about Wednesday night, what you're doing Wednesday night. Can you just fill them in a little bit about that?
Oh, yes. Thanks so much for reminding me, Liz. So, the Bleeding Disorders Council of California, we will have a webinar Wednesday evening at 6:30, and we will also be, going into pretty deeply into the policy actions that are going to impact Medi-cal in California as a result of HR 1. Some you'll hear a few of the things I've shared again, probably if you join us, but there will be a lot of additional information. So I will pull that link and throw it in the chat if anyone wants to register for that webinar.
Perfect. I'm going to ask everyone to come back on, and we're going to have a little bit of a round table. And there are questions, but let's just ask you guys the questions that we'll start with that. To each of you, what is each of your organizations doing to adjust and to advocate? Who wants to start? Connor, do you want to start?
Sure. When the May revise was released, we obviously we saw these utilization management provisions. We were strongly opposing those, and now that those have been included in the enacted budget, I actually last week reached out to some contacts at the Department of Healthcare Services to try and glean some additional details, figure out if these are going to be across the board, prior auth and step therapy protocols, just to try and work with them, make sure that we stay up to speed with the process as they sort of hash out the details. And I think our strategy will come together as that process continues. And it very likely that we'll be activating our grassroots network and trying to get the patient voice involved here.
Thank you, Connor. Casey, do you want to take that?
Sure. So I'll start by just saying, there are a lot of questions, and Lynn pointed this out, spoke to this as well, but there are a lot of questions around Medicaid right now. I think a lot of people have questions and they don't necessarily know the answers. There's a lot of things and headlines being thrown around. And so one of the things that we're really trying to do through our clinicians, at least, is to educate them. I think we recognize that oftentimes patients, their first kind of point of questioning will be to their healthcare provider. And so we want to make sure that our providers are educated, or at least if they don't have all the answers, they know where to go to get the answers. And so trying to take these high level topics and break them down into layman's terms and make sure that someone who's not a policy guru or a wonk or anything has a place to go to get solidified answers is big. I think, there was a lot of question marks, a lot more question marks maybe 2 months ago than there are now. Now we have a little bit more of an indication as to what is actually going to be happening. I think the implementation and the follow through is always tricky. And so to Connor's point, we're trying to understand how that's going to be done. And then, as far as mobilizing our clinicians is saying to Connor's point, where can we be a resource? Where can we work with the folks that are going to be implementing these things to make sure that the patient and provider perspective is not lost as these decisions are being made?
Great, thank you. And Lynn?
Yeah, so I mean, like the webinar that we're hosting tomorrow night, right? I think the a real issue is trying to ensure that patients kind of understand what's happening. Part of that right now is like reassuring patients that this isn't all of the changes are not taking effect immediately, right? And so as much as it is all very concerning, it doesn't necessarily mean that you're losing your healthcare tomorrow, which is important. We want people to be able to continue to access their healthcare and, be consistent with their medications and all of those things. And then work again, things like the enhanced tax credits, right? Ensure that where we still have an opportunity to ask our members of Congress and leaders to implement things that can still be a help and ensure that fewer people are impacted by these changes. Like those are things that we want to do. I also think in California we're in a little bit of a unique position. Some of what is happening with Medicaid, there are states that are, rushing ahead and implementing things more quickly. And in California, I think our department is disposed to want to try to ensure that folks continue to have as much coverage and access to care as possible. The problem is they are dealing with massive budget cuts, right? So the money has to come from somewhere to pay for this healthcare, and they're, I think, going to try to do this as thoughtfully as they can, and hopefully minimize the impact on patients. And again, as my colleagues have already said, that's where we can be a resource and really try to help them see where certain policies are going to be more negative on patients and their health.
Yeah, thank you guys so much. And let me just add, I'll give a plug to My Patient Rights. We have the portal, it works in all 50 states. We need to know what's happening to you. And one of the best ways to understand what's happening to you is if you contact us, if you go through the portal, if you share your story, your story does not have to go public. It can be private and we'll just receive it. But if we don't know what the trends are that are happening out there, it takes longer for us to find out and figure out how we can best help you. Your voice is so important. Every single voice matters. And Lynn talked about the letter or going into their portal to send a letter out. That is really, really important. We are also co-sponsoring SB 363, which is the denial and independent medical review overturn, to understand how many are what's happening to people when they have to go through a prior auth. What happens to people when they ask the department? So our bill goes a little deeper. It has much more transparency in it, and it's still moving. So fingers crossed that we get to the floor pretty soon. We get it out of suspense. But and also just a caveat to that is at the federal level, and when we send this out, I'll send you some other resources to go with that. And maybe Lynn, if you can put in the chat the link to where people can go for their to get into that letter. CFR 42 was passed that actually goes into effect in January of this next year, I believe, which will make all plans, Medicare and other plans, responsible for sharing their denials and their overturns. Super excited to find that that they were kind of in sync with us, and we're actually taking some language out of what was passed in Congress and adding it into 363. So stay tuned for that. Your voice is really important. We have letters also that are needed to go to appropriations right now. And certainly if you have letters like your Lynn was talking about, Department of Healthcare Services, Department of Managed Healthcare, they need to hear from you. It really does matter. Your voice does matter. So I'm going to thank you guys. We have a few more minutes, and we do have some Q&A. So let's see what came in here. I see, Connor, that you answered. If you want to go over that, our Medi-cal health plans overseen by the Department of Managed Healthcare. Is the DMHC responsible for secondary appeals to denials or prior authorization? So I think you had a really good answer.
Right. So I responded here in the chat. If you want to read that, it says, I wrote that the Department of Healthcare Services is the primary administrator of Medi-cal and regulator of Medi-cal. And the Department of Managed Healthcare is the agency that determines whether private health plan denials qualify for that independent medical review that we talked about. So I think it sort of remains to be seen whether Medi-cal prior auth appeals will go through that same DMHC process or whether it will go through some sort of DHCS process. So stay tuned.
Can I add on to
Yeah.
that, Connor? I think
Mhm.
you're right. I think we don't 100% know for sure, but um, I do believe that the Department of Managed Healthcare has a certain amount of oversight over the managed
Right.
care plans because they
Yeah.
are private companies. Obviously, the Department of Healthcare Services manages those contracts and sets the parameters as to what they're supposed to do. But to clarify, pharmacy benefits were all carved out from Medi-cal managed care when we created Medi-cal RX here in California. And so my best guess would be that, Department of Healthcare Services would continue to manage that because all of those are managed by, go through a company that the state contracted with, Prime Therapeutics, who manages Medi-cal RX and processes all of those. Now, I will say our bleeding disorders community had extensive experience with Prime Therapeutics and Medi-cal RX when it was first launched a few years ago. Initially, it was kind of a mess, and there were a lot of delays and hiccups, which over the first, say, 6 months or so of the program were worked out. And at this time, they have a very fast response time. And what remains to be seen, though, is if they get suddenly hit with a whole lot more prior auths that they weren't processing previously, how much that's going to slow down the process and how they're going to respond to that. Are they going to bring on additional staff in order to keep that? Because I actually think that currently the processing rate is like 24 hours that they get back to folks, which is great. And we would love to see that continue to be the case, but that remains to be seen. So
Yeah, thank you. And we talk about PBMs a lot, where their hands are in all of this. And we're hoping that SB 41, I'm plugging some of our bills, really important bill on PBM reform is still also moving, and your voice is really important. I remember when I was watching the hearing and they were talking about actually cutting um, the asset limit. I almost fell off of my chair when they started to talk about the asset limit, that they were going to go back to like 1980 amounts, like 65,000, which means that if someone had two cars and you had a family and we don't have wonderful public transportation and you need to take your child to the doctor, how are you going to get there? Oh, no, sorry, you can't have that second car because it would put you over the limit of assets. So I think there was so much noise from the patient community that they reinstated it back to what it was at $130,000, and that issue was won. So all of these issues for all of our organizations are so vitally important. We need to know, one, how is it affecting you? Two, stay up to date, like Lynn said, on the things that are coming out. And we have our e-news. If you haven't already signed up for our e-news, please do. All of our groups here put out great information. We try to put as much up on our website to keep you up to date on things that are happening. We have had media. We've had quite a bit of earned media op-eds put out. It's really important that they hear from you, and don't be afraid for them to hear from you. And if you need us to help you, let us know, because we're not afraid. We're not afraid to have our voice heard, and it is vitally important. We're going backwards, and we know that we had made so many steps forward in there because of what we're looking at in the budget. So it's all about the money. But if they think not treating someone for obesity and then having them gain all their weight back or get sicker or having more complications is going to save them money, they are wrong. It is not going to save them money, and we have data that shows that. So I think that there's a lot we can do. I would say, do not feel sad. Keep up your hope in your heart and take action. Because if you are silent, no one will know and no one will care because they don't know what you're going through. And we are here to help you. So please, 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 let us hear from you. I have a couple other questions. Where do people go for help? They need help. All of a sudden, all these are implemented, and they just don't know. Are they going to get their Medi-cal? Are they going to be cut off of their Medi-cal? We're looking at, the undocumented and Medi-cal cuts. So what's going to happen to them? So anyway, I just want to open. Does anybody want to take that? We have a few minutes. We have 3 minutes left.
I mean, it's challenging, right? Hopefully, I would say providers are a great resource, right? Talk to your provider. They may be able to point you in the right direction. If you are, within our bleeding disorders community, we certainly seek to help support our patient population and help them navigate through these things. Um, so other patient groups, I think, are a great resource to try to reach out to get support, to get information, to get help. Um, Again, reference go to Medi-cal and look up your account and read the information to navigate those things as well.
And
Connor.
I'll said groups, nonprofit organizations with patient navigators, such as Susan G. Komen. Although the patient navigators are probably, trying their best to stay up to speed with all the very rapid changes that are going on. There are very skilled professionals out there to, their job is to help cancer patients, patients with other chronic diseases navigate the very complex healthcare system. They can help you figure out what public programs you qualify for, which ones you don't, and possibly direct you to financial assistance programs. So definitely urge you to check out Komen or other local nonprofits. I know that there are several local nonprofits specific to breast cancer in the Sacramento area that are great that I've worked with. So just check out those nonprofits and see how they can help you.
Yeah, and we'll add that to a list as when we send this all out. The recording, you'll probably have it in the next few days, and we'll send out the PowerPoint. And we are working on quantitative and qualitative studies that will know how negatively or positively this is going to affect. We just met with they're not a new company, they're new to us. And we're going to be working closely with them on getting the data. And so if you have data, if any of your organizations have data, please feel free to share with us. The data is going to be critically important. I know we're up on the 11 o'clock. We got through a lot of information, and so I'm hoping that this was worth your while. It certainly was mine. You guys are such great voices and have so much good information for the public and for all of our nonprofit world. This is a different time for us, and we've got to ensure that the patient stays at the center of all discussions and that we don't lose sight of their needs. We don't want to lose patients because of policy. So thank you all for attending. Casey, Connor, Lynn, thank you guys again so much for taking time out of your busy days. We are getting the information out on the newsletter, and thank you for asking those questions. And we'll also again get out the information. Lynn put it in the box. I think Mary also put it in the box of the webinar that will be taking tomorrow night at 6:30. I believe you said, Lynn, starts at 6:30, so it's after your work day. So it would be unless you're on the East Coast. but that it's still worth your while. Even though it'd be 9:30. But thank you guys again. Watch for more information coming from the Chronic Care Coalition, the work we're doing with our sister organization, with the Chronic Care Policy Alliance, with the federal work that we're doing, with all of our partners that you're seeing here right now, with all of our other partners that give us so much to make sure and ensure that access to quality healthcare is obtainable for all that need it. So thank you. Have a great rest of your day, and we will check in with you again soon.
Thanks,
Thank
everyone.
you.
Thanks all.